All right. So my clock says 3:30 Pacific time. So let's just get rocking and rolling. I want to welcome everyone. We are here at the Healthcare Supply Chain Hub doing our 30-minute free weekly learning bites. We do this every Tuesday and Thursday. So I'm so glad that you guys are all here. So let's get into this training today. So I want to just start off with, is this you? Are you stepping over $1 to pick up pennies or dimes? And when I say this, you're like, what does that even mean, Angelique? This means, are you being stuck in the transactional and not moving into strategic thinking? And when I say, are you stuck picking up pennies or dimes? Are you chasing your contract dollars? Meaning, I got to get another dollar off. I got to get another penny off. I got to get another dime off. Or are you taking a look at your contracts from a total cost of ownership standpoint and thinking strategically the total cost of that contract? So that's actually what we're going to dive into today. So let's get into it. All right, some key takeaways today for this learning bite are: number one, transactional sourcing only looks at price. It feels like savings, but often increases your total cost. So, we're going to dive into why that is, what that looks like, and other costs you're actually missing within that sourcing initiative. The next bullet point there is chasing pennies actually creates churn. I don't know if you know this, but vendors lose trust in customers who are constantly asking for a better price, better price, better price, better price. But they also lose trust in customers who ghost them, do an RFP and never reach back out, all these things. So you need to make sure that you're not creating churn. Also, clinicians lose patience. What has always been our brand here in the supply chain? It has been, you look for the cheapest stuff and you put it on our shelves. Well, we don't want to be that. We want to be partners with our clinicians. So we don't want them to lose patience. And then outcomes don't improve if we're not being strategic. So I'm going to kind of share with you here in a little bit why that is. Strategic sourcing actually looks at total cost of ownership and considers quality, utilization, downstream impact, thinking about the waste of that item, reimbursement, revenue, all those things that kind of drive total cost of ownership, total cost of care, even with that product, equipment, or technology. Category management beats one-off contracts. And we're going to kind of go over the category management model so you can see what that looks like. And bundling spend gives leverage and it drives alignment. So we're going to kind of go into what is bundling spend, why do you need to do category management, and why all that is important to be in strategic thinking mode. And then clinical alignment is critical. Think clinically integrated supply chain. You surely do not want Angelique choosing what is on the shelf. Heck no, I am not a clinician. I don't know what is the best to be utilized on our patients. So without clinician buy-in, savings just rarely stick. And you're going to do a lot of wasted time backing out of initiatives, and it's just is not good. If you want to think about the last bullet point, strategic equals sustainable. Think of that as a motto. Transactional might win a battle, but strategic sourcing wins a war. So that is the important piece there. So those are our takeaways for today. So let's kind of get into transactional sourcing defined. What we're doing here is we're focusing on lowest unit price, chasing pennies, chasing dimes. I'm running after, can I get a lower price, cheaper price, lower price, lower price, lower price, lower price? What is that really doing for you? You think that you're saving tons of dollars by chasing a lower price, lower price, lower price, lower price. And I want you to really sit and think about that for a second. It's very transactional work. It's reactive. We're doing one-off contracts just to save a couple pennies. And those are not strategic contracts that are long-term. I take a look at how many contracts are in our entire portfolio at the health system I work at today and say how many are 1-year contracts. We want long-term contracts, 2-year, 3-year, 5-year. We want to lock in the price. We want to show vendors that we are a strategic partner. We're not just chasing them to get a deal. It sounds like very, very much like a used car salesman, right? We don't want that. We want something that sticks. So the other piece of the puzzle is executing and forgetting your contract. How many times have you signed a contract, put it in your contract repository, whether that's Workday, PeopleSoft, Oracle, Infor, Lawson, and then you never looked at it again. You never even had a business review with that vendor during that 3-year contract. That is a shame. You need to be watching your compliance of that contract. Are you doing well? Are you getting the outpatient outcomes that we said or promised that we were going to get when we decided to bring that product in? All these things are super critical. So, an example of that, chasing glove price drops. How many times have you changed glove vendors because you're looking for the next time the price drops? That is very, very transactional. That's transactional sourcing. And honestly, I kind of even call that just pencil pushing contracts. If I just wanted a contract administrator who just pencil pushes contracts all day, I can just get like a paralegal to do that, right? We're looking for people who want to deep dive into healthcare supply chain sourcing and figure out how the entire connection fits with clinical engagement on the back end, trying to figure out what's our quality data, length of stay, readmissions, post-care infections, all those things that are important and how they tie back to that contract. So that's kind of what we're looking for. That gets us into what is strategic sourcing defined. And this goes into total cost of ownership. You're going to hear me say this through my certification programs. I train all about it. You're going to hear me say this over and over again. I have this widget right here, and this thing cost me 27 cents. Well, I need to know actually how much it is costing me all the way to patient consumption, to throwing it away and having it be waste, to reimbursement, to the revenue this thing brings me. That's total cost of ownership. And when I am comparing two things side by side, this thing might be 27 cents and this might be 57 cents. Does that mean I automatically go for the 27 cents item? Historically in supply chain, that is what we do. We chase pennies and dimes and we step over dollars because in the end, after waste, after tariffs, after reimbursement penalties that the lack of quality this thing is driving, you have to remember that I may be paying $1.75 for this white one, and this gray one still is at 57 cents. Those are the things you should be looking at when you're comparing an apple to an apple, or else you're going to be comparing an orange to an apple. Okay. All right. Next thing is value-based long-term relationships. What is value-based care? Well, you guys all know that years ago we switched from fee-for-service to value-based care model. And the value-based care model really dictates from CMS this whole concept of, hey, you're going to get reimbursed based on quality outcomes, length of stay, readmissions, all of your quality metrics that go along with it. But also keeping your patient in your network. them not hopping to another health system for care. There's all different types of requirements that kind of go into value-based care, but the premise being you can no longer just bill for services and add-on services and another service, and the next day the patient has another service and another service. It's not churning and burning your patient. It really is based on the quality of their care. And do they stay with you? And are you a trusted partner in their healthcare? So when I look at that from a supply chain standpoint and how we lean into that, this actual medical device, let's just say this is a medical device, it better be producing the quality of care on the back end that's going to get me full reimbursement from my insurance company, whether that's Medicare, Medicaid, private payer insurance. This thing better be getting me all of that. And if not, how do we go into a partnership with our suppliers that are risk and reward, where they share in the risk of our reimbursement on the back end? And then that literally is the shift within healthcare and healthcare supply chain that I have been doing a lot of work investigating over the last probably year, really figuring out how does healthcare supply chain fit into that value-based care model. Because historically, if I could just pump supplies into the pipeline and into the workflow, and we could just bill for those things, fee for service, hey, that was great, but those days have come and gone. And now it truly is, what is the value of care to that patient? And that's what they're going to get billed for. And that does not mean I can add 500 items or medical devices or whatever it may be to one patient case any longer. So that goes away. And so an example from a supply chain standpoint is, do we have category management of our surgical supplies? And then really what really fits into that product category that is billable to a patient case? There's a lot of times historically you could look at insurance bills in, let's just say 10, 20 years ago, and something was billed to a case that didn't even belong in there. This is why we want to have service line teams within supply chain. We want to have supply chain team members being SMEs, subject matter experts of the categories that they manage. And then let's work together with the clinical service line teams to say, hey, let's tackle our cases or our clinical practice that is really suffering from a reimbursement standpoint, and see if the root cause was a piece of equipment, was a supply, was a medical device. And let's solve for healthcare supply chain and the value-based care model at the same time. That is truly the definition of clinically integrated supply chain. Angelique not making decisions from a supply chain standpoint, physicians making sound decisions based on patient outcomes and how our patients' reimbursement model and how their the quality of their care is dictating what we choose, what's on our shelves. Okay. All right. So the problem with pennies and dimes, and I literally was doing a podcast this week with some friends of mine, and we talked about value-based care versus fee-for-service and how value-based care really is changing my mind about value analysis and how value analysis actually should be a piece of the clinical operational service line model. And that's really where it fits, not as a side load value analysis model that is just literally looking at new product introduction all day long, which I call Santa's wish list, But value analysis, adding value into a service line meeting where they're solving for quality outcomes challenges, length of stay, readmissions. Hey, were we supposed to cut that patient open, or would it have been okay to do that case closed? All these things that supply chain could be in because the supply, the equipment, the technology they were using possibly caused an issue within that patient care or that clinical practice that happened, right? So thinking about the problem with pennies and dimes, then supporting that is it is really cost avoidance disguised as savings. If I write a 3-year contract, and let's just say I'm able to save, let's $15,000 year one. Okay, I can truly probably take that cost savings to my bottom line in year one. But all of you know that from a budgeting standpoint, my budget actually resets itself every single year. So now I know I was spending this much this year. My budget resets to that. I can no longer take that savings year over year over year because my budget's already reset after year one to the new budget amount. So that for me, then that turns into cost avoidance on years 2, 3, 4, or 5, however long that contract is. But the other piece of the puzzle is unless I'm getting cash back in my pocket and inside the health system, like is money going physically back into my pocket? Do I feel it? Do I see it? Then it's disguised, right? And if I look at the total cost of ownership of an item and that item caused a quality issue that gave me a 9% penalty on the back end from a reimbursement standpoint, that literally is just it's not a savings. I can't say that it's a savings to my pocket. And this is where C-suite members need to really start paying attention to your second largest spend in your health system. Supply chain, supplies, equipment, technology, services, purchase services, all of that falls into there, whether that's consulting or that's outsourced services, food nutrition, EVS, all those outsourced services that you may have. You need to really think about, am I so darn worried about what I'm paying for it on the front end that I'm forgetting about what I pay for it on the back end? This also then creates that churn and vendor distrust, right? Because we're just chasing a savings on the front end, but it's really being disguised as savings as its cost avoidance. And it doesn't improve outcomes when we are chasing those pennies and dimes because I'm not asking the clinicians a critical question of, hey, clinicians, my friends, clinically integrated supply chain, how are our patient outcomes with that case, with that surgical case? How are our patient outcomes with that medical device? And if I'm not asking that question and we are not root causing to see if it's causing some of our other issues on the back end, we're doing ourselves a disservice. And then it looks like supply chain only chooses the cheapest stuff, which was always our brand name from a supply chain standpoint for years and years and years and years. We just choose the cheapest stuff, contract for it, and we throw it on the shelf for our clinicians to utilize, right? And we don't want that. We don't want that brand. So I'm thinking about this strategic cure to all this. Number one, having a category management approach. I am going to category manage my products into categories. I'm going to have SMEs that learn those categories inside and out. They are the one source of contract for that clinical or operational service line or operating division, whatever you guys call them. And then they kind of manage their portfolio of contracts that sit within that category. I can see where I can bundle, contracts, where I can bundle product categories. And that's where we can kind of work on the volumes. Number two, using our spend analytics, whether it's your benchmarking company, whether you're using ECRI or something like a Lumiere or a ClearEdge or a Vizian Savings Actualizer or Premier's tool, whatever tool you have out there. My hope is that you have analytics teams sitting in your supply chain team. How are you using your spend analytics to compare costs, but also pull in the quality data that you're searching for and that you need to make accurate decisions in your decision-making governance process? And then number three, aligning your sourcing to clinical outcomes. If I am doing a new product introduction in a value analysis committee, and we did this whole presentation with a financial impact statement, what would revenue look like? Is it reimbursable? That's all great. And then you did a really, really nice clinical evidence presentation. Maybe the surgeon did that to the committee. They did this great presentation. And we said, okay, let's vote yes to bring this thing in. Are you doing a 6-month or a 1-year look back on that initiative to see if it achieved everything that we presented it was going to achieve? Those things are very important to align sourcing with those clinical outcomes to make sure, did we get the outcomes that we promised when we went to pitch that product to get voted yes? And then we want to make sure it's in front of the right people and we build relationships. I would say that my job in healthcare supply chain, strategic sourcing, and contracting is to have great relationships with whoever our stakeholders are within the categories that I manage. So let's just say I manage food nutrition, and EVS. I better be very, very close relationship wise with all my EVS managers, maybe directors, food and nutrition managers, maybe if there's directors, the VP over support services, whoever those people may be. And those are the relationships I need to have. And then on the vendor supplier side, I better have great relationships with my food distributor, my beverage distributor, my coffee distributor, all these things. And from an EVS standpoint, hopefully my pest control company, my linen company, all of these things are very important as far as relationship building. That is my job. If you are in strategic sourcing and contracting and you are the world's most shy, quietest person, it's probably not the job for you. You need to be building strong relationships with your stakeholders and with your vendors. And, look at me. I love to talk and I love to teach and I love to connect and I love to hang out with people. And I do good in strategic sourcing and contracting because it's about the relationships and getting in front of the right people and saying, are you sure? Should we dig a little deeper? Do you want me to put any more data together? Would you like me to pull some more information? Those are the things that you need to be asking. And if you're shy, that's a very, very hard thing to do. And it's hard to get strategic. Okay. All right. So this is the category management model. Now, this slide and the next slide, I'm going to tell you are supply chain 101 tools. When I say supply chain 101, I'm talking about not specifically to healthcare supply chain. This could be retail, this could be manufacturing, this could be distribution, this could be car companies, this could be buying potato chips for aisle 17 in Target. This is any supply chain globally. This is 101. So this is category management model 101 for all supply chains across the world. But remember, I said healthcare supply chain is the most complex supply chain in the world because of the complexity of what we work on. One day, I could be doing a contract for an implant that goes into a patient's body. The next day, I'm working on a contract for food distribution. The next day, I'm working on a contract for a consulting company in to help our finance team with something. Look at the complexity of all of our product categories. It's absolutely crazy. And then you go into the complexity of the spend on these things. And then you go into the complexity of the stakeholders I have to talk to for vetting these things. I'm talking to the C suite at my health system, to a hospital president, to an EVS worker, to a consultant, to a finance team member, to accounts payable. I am talking to everyone across our health system. That is so complex. If I wanted to be in a supply chain job in this country that was pretty easy, I would probably go buy the potato chips for aisle 17 in Target. So see the difference? Super easy. It's not as complex. But anyways, getting back into this category management model, this kind of helps you figure out how to develop a category management model. Now, if I was just, for example, to stick with Nuvia's category management model or Vizient's category management model, there's so many different ones out there. You've got to pick one or build one of your own and stick to it. Don't hop from one category management to another, category management model to another. It's going to confuse your staff. Okay. Stick to one, finalize your categories, finalize the scope of the items that fit in that category. I'll tell you, for example, we struggle a lot with trauma and podiatry. A lot of our vendors put both of those together as one category. I struggle with separating them because it doesn't always make sense that they are together. So you as a team have to figure out what fits into scope, what doesn't fit into scope into your categories. And then you're going to figure out what contracts fit in those categories. And then you're going to assign those categories to your strategic sourcing and contracting team, and they're going to manage those, right? So that's just part of how to manage a category. But this then kind of goes into this in depth. If you take my certification in strategic sourcing and contracting, I go through this in depth and we work through it, and you will figure out how to use this. The second piece that I will say is supply chain 101. And I teach this once again in my strategic sourcing and contracting certification program in much depth, but is the 7-step strategic sourcing process. This is a proven methodology that allows an organization to collect the right data, perform a deep analysis, develop and validate your opportunities, facilitate negotiations, and ensure implementation of any initiative you're working on. This 7-step actually can happen in a retail format, in a manufacturing facility, maybe the GM car line, whatever that may be. This can be used either way, not just in healthcare supply chain. So I teach this. This is very, very important way to kind of step yourself through doing an initiative. However, I will say this helps you stop chasing pennies and dimes on the front end and really figure out your sourcing strategy and how you develop your category and who your stakeholders are and how you identify your selection factors within that initiative, within that category, to drive success on the back end, which is your patient outcomes, and making sure that you're not affecting reimbursement and revenue in any way. So I want to throw this in there, but I encourage you all to take my certification in strategic sourcing and contracting, because we will deep dive why this is so important. So when you think about the change management then within the 7 steps, change management helps to drive strategic thinking. So if I am saying I'm working on pieces of the 7-step strategic sourcing process, where does change happen? And I will tell you, all of you out there are change agents. You are project managers, your facilitators, your collaborators, your connectors, your engagers. You're engaging your sponsors, your stakeholders, your suppliers and vendors and distributors and your GPO. That's your job. And that's why I said you can't be quiet and shy if you're going to be in strategic sourcing and contracting. That does not work. You have to be an influencer. You're helping drive change. Now, you are not the project manager managing the project. You should be facilitating people through the change process, through the decision-making governance, through the decision-making process. That's your job. But I want to make sure that you understand this is strategic thinking. This is strategic sourcing. I am not hunting and pecking through a catalog to find the cheapest thing in the catalog. I may do that on Amazon when I'm trying to buy a comb or a toothbrush or a pen, but I'm definitely not doing that here in healthcare supply chain, especially on items that are not commodity. I can do that all day on commodity items, 2x2 gauze, possibly, things that do not need such decision-making criteria. But on your more important things that do affect patient outcomes, you've got to be doing this. So key takeaway, stop counting bandages. Start managing your categories. Start connecting. Start building relationships. Be strategic versus transactional. Have those partnerships. Suppliers, I ask you to do the same thing. All these things are just as important for you to get your foot in the door at a health system. So I am giving you guys a massive action checklist worksheet that I want you then to take and go do some things within your health system tomorrow. Suppliers, some things I want you guys to be doing tomorrow just as well. I want you to, first off, pick one category to review. And in the checklist, it's going to give you more detail of how to do each and every one of these steps. So you'll have that worksheet and you'll be able to get through it. But I want you to calculate the total cost of ownership for that category. And I'm going to say, shame on you if you don't know where to pull this data. And we're talking even all the way to quality patient outcomes, waste. How do you get rid of that thing in the landfill? Share your spend data and outcomes for one category. Now, you can share it with your VP, you can share it with your teammates, you can share it within your value analysis committee. But I want you to think about moving beyond the price taker concept and discuss partnership, not just quotes with your suppliers. Sit down with your suppliers and say, hey, I ran this one category. This is my total cost of ownership. Wow, this is really affecting our patient quality scores and data. And actually, our reimbursement's going down because I'm using you. That is a strategic conversation. Then that leads into value-based care contracting, the share of risk and reward with our suppliers. We have to start doing that. I want to see health systems across the country starting value-based care contracting. I'm encouraging you and I double dog dare you to do it. And I want you to start a category management pilot on this category that you chose. I want you to red flag any penny or dime chases that you're doing. And then I want you to launch some kind of an initiative calendar that's going to show you initiatives that you want to work on this year where you feel you are chasing pennies and dimes and stepping over dollars all day because you don't know what the total cost of ownership is for those items. Okay. That is your massive action for tomorrow. So I want to thank you guys. I love hanging out with you every Tuesday and Thursday at 3:30 p.m. Pacific Standard Time to learn something new. Hopefully, if it's not new, just maybe you picked up a nugget that you're like, I am not doing that part. Yes, I know what she was talking about, but maybe I'm not doing something. Or, hey, I want to go on the internet and learn a little bit more about value-based care model. Or, hey, I want to really understand total cost of ownership. Or, hey, I'm going to go talk to my VP and say, why don't we have access to this data? Those are all things that at least get your brain moving. I want your brain to be moving. If you guys need to get a hold of me, I've got my website there, the healthcaresupplychainhub.com. Please contact me at customer service at healthcaresupplychainhub.com. And you can also connect with me on LinkedIn. Thank you for being here. I will see you guys next Tuesday. Have a great day.